Hello, welcome back to this part 2 of how to use DSM-5 video. And now we are going to look at the three major components of DSM-5. The three major components of DSM-5 are the diagnostic classification, diagnostic criteria set, and also the descriptive text. For the diagnostic classification, it is the official list of mental disorders recognized in the DSM-5. It includes a diagnostic code, which is typically used by individual providers, agencies of institutions for data collections and billing purposes. The diagnostic code is, as previously mentioned, it is derived from the International Classifications of Diseases, the ICD. Here is how it looks. For example, the neurodevelopmental disorders is coded as 17 in ICD-10. For the diagnostic criteria sets, it indicates symptoms that must be present and for how long to diagnose a client with a certain mental disorders. It also indicates lists of other symptoms, disorder, and conditions that must first be ruled out for a particular diagnosis, and it also to increase diagnostic reliability. For the DSM-5, its descriptive text includes the information about diagnostic features, associated features supporting diagnosis, subtypes and/or specifiers, prevalence rate, development and cause, risk and prognostic factors, functional consequences, cultural-related or gender-related diagnostic issues, and also the differential diagnosis. Now, let's look at how the chapters in DSM-5 are arranged. The chapters in DSM-5 are arranged according to two different approaches. The first approach is about the lifespan approach. The disorders that are more frequently diagnosed in the childhood is arranged at the front of DSM-5, and accordingly until the mental disorders which are more oftenly diagnosed in the older adulthood. For example, the neurodevelopmental disorders, example ADHD, to the neurocognitive disorder like major and mild neurocognitive disorders due to Alzheimer's disease. Another approach that DSM-5 used in arranging the chapters is an internalizing disorders to externalizing disorder approach. For example, depressive disorders is arranged in front of the substance use and addictive disorder, which is an externalizing disorders. And these two approaches, the lifespan approach and the internalizing disorders to externalizing disorders approach, is also applied within each chapters. Here are the chapters in DSM-5. We have neurodevelopmental disorders, schizophrenia spectrum and other psychotic disorders, bipolar and related disorders, depressive disorders, anxiety disorders, obsessive and compulsive and related disorders, trauma and stress related disorders, dissociative disorders, somatic symptoms disorders, feeding and eating disorders, elimination disorders, sleep-wake disorders, sexual dysfunctions, gender dysphoria, disruptive and impulse control and conduct disorders, substance use and addictive disorders, neurocognitive disorders, personality disorders, paraphilic disorders, and other disorders. Before we draw further, I would like to show you a video about how to use DSM-5. I hope that you will enjoy the video.
Imagine that you are a psychologist and Pat comes into your office. He says he feels like he's going crazy. He sometimes feels like he's having heart attacks, but the doctor says there's nothing wrong with his heart. During these attacks, he sweats a lot, his heart pounds, and he feels like he's choking. Sometimes he feels dizzy and thinks he might be dying. How do you decide what's wrong with Pat, and how do you treat him? The Diagnostic and Statistical Manual of Mental Illnesses, or DSM for short, is a text that provides the requirements to diagnose a mental disorder. Think of it like a cookbook, except instead of looking for a recipe to make something, you're eating something and trying to figure out what it is. In this case, you're going to look through the cookbook to match up the ingredients with the name of the recipe. Maybe you are eating something with macaroni pasta, and it tastes pretty cheesy. It's creamy too, maybe it has milk or cream in it. When you look through your cookbook, you notice that mac and cheese has all of those ingredients, and you decide that's what you're eating. That's kind of what psychologists do with the DSM. The book acts as a guide to help them find the diagnosis or name of a mental disorder, such as schizophrenia, bipolar disorder, or autism. Each diagnosis is also given a number to help separate it and speed up referencing other professionals' work. For example, 315.1 is mathematics disorder. The text also has informative statistics, or the mathematical description of disorders' cultural, familiar, and gender prevalence. For example, 1% of the population has schizophrenia, but if your twin sibling has it, your chances go up to 50%. Let's look a little closer at how psychologists use the DSM to make diagnoses. Think back to Pat. He's got symptoms, like ingredients, and you've got to put the symptoms together to diagnose what's wrong with him, like choosing the recipe from the cookbook. Mental disorders and their symptoms are found in the DSM, but as the psychologist, it is your job to determine which diagnosis is correct. You start by looking at all of Pat's symptoms: feeling like he's going crazy, feeling like he is having heart attacks, sweating, heart pounding, sensation of choking, dizziness, feeling like he is dying, and no medical issues with his heart. Together, these symptoms make up a constellation, or a group of symptoms. It's called a constellation because it's as if each symptom is a star, and you, as the psychologist, need to identify the correct constellation, or disorder, the star belongs to. Pat's constellation of symptoms have a lot to do with anxiety, such as the feeling of going crazy or dying, and the physical sensation of a pounding heart. Luckily, the DSM is divided into sections. Some of these include childhood, mood, sexual, anxiety, and sleep disorders. They are all very broad categories, and in each section are the individual diagnoses. You open up your copy and find the anxiety section. It opens with a short paragraph of the many anxiety conditions. You find that a brief description of panic attacks is very similar to your client's symptoms, so you go into the full text to learn more. The section for panic attacks says you need 4 symptoms that begin abruptly and end within 10 minutes. Your client has 7 physical symptoms, and they are not caused by a medical condition with their heart. Your client is having panic attacks, but as you continue to read the criteria, you see that panic attacks themselves aren't actually a disorder. They are part of a disorder called panic disorder with or without agoraphobia. Now, agoraphobia is a fear of public places and people. Pat came to your office, so he does not have a fear of public places and people. You think he might have panic disorder without agoraphobia. Along with a description, each disorder has a checklist. Let's check Pat's symptoms against the checklist for panic disorder without agoraphobia. Must have panic attacks. Check. Client feels like they are going crazy. Check. No agoraphobia. Check. Not due to a medical or alternate diagnosis. Check. You diagnose Pat as having panic disorder without agoraphobia. You write this in the patient's charts and have successfully used the DSM to make a diagnosis.
Welcome back. I hope that you have enjoyed the video. Now, we have a question. How to determine a diagnosis using DSM-5? How? Let's look how. First, we have to look at the diagnostic criteria set. The diagnostic criteria set, as previously mentioned, it includes the information about the symptoms, behavior, cognitive functions, personality traits, physical signs, syndrome combinations, and durations that require clinical expertise to differentiate if this is really a mental disorder or is just a normal life experience due to the day-to-day events or stress. And each diagnostic disorders might have different combinations of symptoms, and all of here, they have different combinations. Let's have an example on major depressive disorder. For the diagnostic criteria set, we can have a look with the diagnostic criteria set A1. Depressed mood most of the day, nearly every day, and also markedly diminished interest or pleasure. And these two actually reports to the symptoms and behaviors of the diagnostic criteria sets. We can look at the significant weight loss while not dieting or weight gained. These are physical signs. Insomnia or hyposomnia, physical signs. Psychomotor agitation or retardation, behaviors. Fatigue or loss of energy, nearly everyday behaviors. Feeling of worthlessness or excessive or inappropriate guilt, cognitive functions. Diminished ability to think or concentrate. Recurrent thoughts of death are also reports to the cognitive functions. Next, the criteria set also includes this. It stated that the symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. This criteria is very important because it's essential to determine patient needs for treatment. If the symptoms does not cause clinically significant distress or impairment in major areas of functioning, the client might not need the diagnosis as he or she might not need treatment as well. Also, the diagnostic criteria of C. The episode is not attributable to the physiological effects of a substance or to another medical conditions. They are dedicated disorder to aid in diagnosis, for example, major depressive disorder due to a substance or medical conditions. We can diagnose the disorder as depressive disorders due to another medical conditions. But if the clinician know that the disorder is due to a substance or another medical condition, the clinician should not diagnose the client as having a major depressive disorder, but rather the clinician should use this diagnosis to diagnose the client. Now, let's talk about the subtypes and the specifiers of the disorders. And these are for increased specificity. For the subtypes, they are mutually exclusive and jointly exhaustive phenomenological subgrouping within a diagnosis. It's indicated by instructions like specified whether in the criteria set. For the specifiers, they are not mutually exclusive or jointly exhaustive. More than one could be given on a particular patient, and it is indicated by instructions like specify or specify is, if. Now, we have an example about the anorexia nervosa. This is about the subtypes. You can see from the DSM-5, it instructed the clinician to specify whether it is a restricting type or it is a binge eating and purging type. If the clinician determined that the client is about the restricting type, this should be reported anorexia nervosa, restricting type. For the specifiers, there are four major types of specifiers. The cause, the progress of the mental disorders, for example, in partial remissions or in full remissions. Severity, indicated by specified current severity. Descriptive feature specifiers is to convey additional information to plan further treatment program. And also the provisional is given when a strong assumption that the full criteria will ultimately be met if the client currently does not present the full criteria of a particular disorder. Now we have a look at the example of a major depressive disorder on the cause and also the severity specifiers. Here is the table that is included in the DSM-5. For example, a client is diagnosed with a major depressive disorder, and this is a single episode, mild, and the progress cause is also in partial remission. This should be reported. Major depressive disorder, single episode, mild, in partial remission. Now let's look at these descriptive feature specifiers. We can have a look from the DSM-5 specifier for depressive disorders. Specify if the client presents depressive disorder with anxious distress. There are some of the criteria for these specifiers and the severity of these specifiers. To report, for example, a client have depressive disorders with anxious distress and the severity is mild, the diagnosis should be reported in this form: major depressive disorder with mild anxious distress. Okay, now what about the full criteria are not met? What about the full criteria are not met? Other than the provisional, which a strong assumption the criteria will be met in the future, if there is no strong assumption, what to do? If the full criteria are not met, the clinician can consider if the symptoms presentation meets criteria for another specified or unspecified designation. The other specified disorder category is to communicate the specific reasons that the symptoms presentation does not meet the criteria within a diagnostic class. For the unspecified category, when a clinician can use that when there is no further way to specify or to describe the clinical symptom presentation. For example, for bipolar and related disorders, there are the other specified bipolar and related disorders. There are four included in the DSM-5 like this: short duration hypomanic episodes 2 to 3 days and major depressive episodes, hypomanic episodes with insufficient symptoms and major depressive episodes, hypomanic episodes without prior major depressive episodes, short duration cyclothymia less than 24 months. If the client presents other specific bipolar and related disorders with the short duration cyclothymia, The diagnosis should be reported in this form: other specific bipolar and related disorders, short duration cyclothymia, less than 24 months. Now let's look at the steps in writing a diagnosis. First step is to locate the disorder that meets the criteria. Second is to write the name. The third is to specify the subtype or the specifiers. Fourth will be to find the code name, which is the ICD-10. And finally, arrange multiple diagnoses together. This is a case study. This is a link for you to download a case study for the following example. You might need your DSM-5 DAX reference beside you to further the understanding. Now that's the end of this part 2 of video on how to use DSM-5. I hope that you enjoyed this video. Thank you.